Hello, everybody. We are going to go ahead and get started today. Welcome to the National Colorectal Roundtable Cancer Screening Data Set Update, where we have a variety of data sources and experts who are going to be joining us today to talk about the 80% goal by 2018 and how we're doing with our efforts. So I'm very excited on behalf of the National Colorectal Roundtable to join all of you today, and thank you for Emily, Caleb, and all of the team who put on the great effort to make sure to bring us all together today. So today's purpose is really to look at the different discrete data sets, particularly NHIS, BRFSS, UDS, and the HRSA data set, with key national experts as well, leading us through some discussion to tell us a little bit further about what we know for the different data sets for different populations and how we're doing reaching that 80% goal. And so again, this goal was established, the 2018 80% goal, but it's very exciting to see that that goal has now been extended 80% in every community. And I think talking about these specific data sets and how we're actually going to be reaching the subsets of the populations that are most in need is going to be really pivotal moving forward, and we'll be able to really frame up some of that discussion in those data sets today. So on behalf of the Colorectal Roundtable, I'm Andy Dwyer. I'm the moderator. I'm from the University of Colorado School of Public Health, and a joint appointment also was by Colorectal Cancer, and worked very closely with the Roundtable over really the last decade, and a steering committee member. Dr. Janava Joseph from the CDC, who's the Centers for Disease Prevention and Control, and one of the chief cancer control officers, is going to be joining us today, as well as Mew Ratten, Mew, I definitely tried to practice, but Mew Ratten Wattenkool, who's going to be joining us well from HRSA and sharing some perspectives about their data sets as well. Mary Barton from the National Community for Quality Assurance in CQA, who's going to be sharing also perspective. And then Stacey Fedwa is going to be joining next right after me to present some fantastic data based on the American Cancer data sets as well. I'm going to have each presenter share a little bit further about their role and background as they get ready to present. We are on a super tight timeline today to share some fantastic data. So I'm going to be asking everyone throughout the course of the presentation if you can go ahead and offer and to interrupt any of the question and answers, questions that you will have throughout the webinar. We will be entertaining those at the close of the discussion. So in the Q&A portion to the side, you will note that there is the opportunity for you to key in today's questions. So again, we do definitely want to try to get to as many of those as possible, but we only have limited time. So anything that we do not address today, we can definitely do in some follow-up activity as well. And just a quick note that the NCCRT has done a fantastic job with the support of the team and staff and all of the members to share information about our data in progress. So just a quick reminder that if you can please make sure and check out the webpage, the homepage from the NCCRT site to check today's presentations as well as data sets that we are sharing real time. We'll have all the latest and greatest information saved onto the nccrt.org data progress spot on the website. So we're very excited again to get kicked off today to hear this data. This is actually some of the data that was shared at the annual roundtable meeting, and I think we're getting some additional perspective even in today's broadcast, which we're super excited about. So I am going to pass the baton to Stacey, who's going to be sharing, again, the American Cancer Society data. Before I get started and pass that off, I just want to make sure, Emily, are there any other instructions that I have failed to mention today?
I think the only last thing is that we will be sending out an evaluation after the webinar to, we're always hoping to improve on what we're doing, and so would greatly appreciate it if all of you would share your feedback. So thank you.
Fantastic. And as the evaluation task group lead, I should have mentioned that before, so thank you so much, Emily. I missed that part. Okay, so with that, I'm going to go ahead and advance the slide, and we will go ahead and have Stacey take over from here. So Stacey, I have made you presenter, and I think you can take it away.
Stacey, if you're talking, you might be on mute.
Oh, I am talking. Sorry. And I'm Stacy, and I am an epidemiologist at the American Cancer Society in the Surveillance and Health Services Research Department. And I have a little bit of a cold today, so hopefully you can hear me okay. And I'm presenting data on the National Health Interview Survey, which is actually not sponsored by the American Cancer Society, but this is some of the data analyses that we've run here, looking at colorectal cancer screening trends in the past 15 years. So I wanted to provide all of you a little bit of an overview of the National Health Interview Survey in case you're not familiar with it. It's a cross-sectional survey that's conducted annually, and it's a household survey, and all the data that I'm presenting are self-reported. It's nationally representative of the target population, which is among non-institutionalized people, so people who are incarcerated or are overseas in the military are not represented in this survey. And although the survey is annual, colorectal cancer screening data are only collected every 2 to 3 years in the years listed here. As part of the cancer control supplement that is sponsored by the National Cancer Institute as well as the CDC, and they make the data available for researchers like me and others to analyze, which is a really great resource for us. And I just was going to tell you a little bit about how people are asked about their screening. So first, people are asked if they've ever had a colonoscopy. Then they're asked how long has it been since your most recent colonoscopy. And then they're asked if it was done for routine or diagnostic reasons. And then this series of questions is repeated for FOBT and FIT as well as sigmoidoscopy. And I should mention that CT colonography was asked about in the most recent survey, but I'm not including it in this data presentation because I'm more focusing on trends over time, and I wanted to keep the definition of up-to-date as similar as possible across the surveys. And to that end, I'll start going into some of the results. And here is the colorectal cancer screening prevalence among 50 to 75-year-olds. And the definition here includes a colonoscopy in the past 10 years, sigmoidoscopy in the past 5 years, or a stool test in the past year. So you can see that colorectal cancer screening prevalence has increased over time, and it's similar among men and women. And in 2015, the colorectal cancer screening prevalence was about 62%, which is up from about 57% in 2013. And this graph shows the same data in a little bit different way. So in this figure, I calculated how much the colorectal cancer screening prevalence has changed in between each survey using prevalence ratios. So for example, between 2003 and 2000, the colorectal cancer screening prevalence increased by 17%. And then next, between 2005 and 2003, it increased by 8%. So you can see that colorectal cancer screening prevalence has been increasing in each successive survey except for between 2010 and 2013. And in the most recent data, there's been about a 7% relative increase comparing 2015 to 2013. And next, I'm going to show a series of slides of trends in colorectal cancer screening by different sociodemographic factors. So for this slide, I'm showing it by age. And colorectal cancer screening prevalence has increased across all age groups. But as you can see, it's increasing more slowly among people 50 to 54 years of age. And in 2015, less than 50% of those between 50 to 54 years were up to date with colorectal cancer screening compared to people 65 years and older where prevalence is well above 70%. And next, I'm going to show the colorectal cancer screening prevalence by race ethnicity. And here you can see, again, colorectal cancer screening prevalence is increasing across all race ethnicity, especially among whites and blacks, where blacks' colorectal cancer screening prevalence appears to be approaching whites. But despite these increases, you can see that Asian and Hispanics have lower colorectal cancer screening use than whites. And among Hispanics, the screening prevalence is below 50%, and among non-Hispanic Asians, it's just above 50%. And by education, you can see that colorectal cancer screening has increased across all educational levels. For example, the colorectal cancer screening prevalence among people with less than a high school diploma was less than 30% in 2000, but it's approaching 50% in 2015. And despite these increases, you can see that the educational attainment disparities are quite wide, and in fact, the disparities in education are greater than that of race and ethnicity, which I know is a little hard to compare because I haven't shown them side by side, but that's just another point that we can kind of consider when we're thinking about target populations to reach. And lastly, I wanted to show trends according to insurance type. And you can see that colorectal cancer screening is well above 50% for privately insured and Medicare insured. But for Medicaid and uninsured people, the screening prevalence is still below 50%. And the other thing that I wanted to point out about this slide is that in 2000, the proportion of Medicaid insured people who are up to date was similar to the uninsured rate, but you can see that the improvements in the Medicaid insured have outpaced those among the uninsured. And next, I'm going to kind of switch gears a little bit. And what I'm going to show is pie charts, and on the left, I'm showing the characteristics of all adults 50 to 75 years of age. And on the right, I'm showing the adults who are not up to date with colorectal cancer screening. So on the left, among all 50 to 75-year-olds, about 73% are white. But when we look at those who are not up to date with colorectal cancer screening, you can see that whites represent about 67% of those in need of screening, and that Asian and Hispanics are disproportionately represented in those in need of screening. Although when you look at the people who need to be screened, most of them are white, followed by Hispanic and Black. And similarly, this is looking at, again, on the left, you see all adults 50 to 75 years of age. What are their insurance characteristics? Well, about half have private insurance and about a third have Medicare insurance, whereas only about 6% have Medicaid insurance and about 6% are uninsured. And among those who are not up to date with colorectal cancer screening, those who are Medicaid insured and uninsured are disproportionately represented, but we also see that most people who are in need of screening actually have some type of insurance. About 50% have private insurance and about 26% have Medicare. And again, this is similarly shown for education. And on the left, you can see that there's a variation in educational attainment among all adults 50 to 75 years of age. And on the right, you can see those who are in need of screening, and about 17% of them have less than a high school degree. 28% of them do have a high school degree, but a pretty substantial proportion have some type of educational attainment that's at a college level or above. And on this slide, I'm showing the same thing by age. And on the right, the most common age group that's not up to date with colorectal cancer screening is those 50 to 54 years of age, which kind of goes back to that point that I was making earlier that the screening prevalence in this age group is quite low. So in summary, there is a moderate increase in colorectal cancer screening between 2013 and 2015, and about 62% of those 50 to 75-year-olds were up to date with screening in 2015. The screening prevalence in men and women are similar, and the up-to-date screening prevalence is less than 50% among these groups, 50 to 54-year-olds, Hispanics, people with less than a high school diploma, the Medicaid and uninsured. And when we kind of look at the data a little bit differently, looking at the characteristics of people who are not up to date with colorectal cancer screening, which kind of incorporates the background population and characteristics of 50 to 75-year-olds. Over a third are 50 to 54, 2/3 are white, over half have some type of education, a college education, and most have insurance, whether it be private or through Medicare. So strengths of this data set is that it's nationally representative. We have ability to analyze trends, has relatively good response rates, and there's timely questions related to policies and physician recommendations. However, some limitations are self-reported data, and although the concordance between medical records and self-reports is pretty good, screening is often over-reported. It lacks data on certain subgroups, and the response rates are declining. And to address some of these declining response rates, the NHIS is going through a redesign, which will be launched in 2019. And I should mention that the colorectal cancer screening questions were fielded in the 2018 survey, and they'll be released in 2019. But in the future, there will be an annual and rotating core of questions, and I'm not sure how frequently cancer screening will be fielded, as you know, ACS doesn't sponsor this survey, so I don't really quite know when that schedule is going to be put online. So with that, I'll thank you, and I'd like to pass the baton to Janaba, who will talk about BRFSS data.
Okay, great. Thank you, Stacy. So I am going to talk about BRFSS. Oops, and I said CRCCP, but ignore that. So just briefly, for those not familiar with BRFSS, it is a cross-sectional telephone survey that's conducted by state health departments that uses landline and cellular phones with technical and methodological assistance from CDC. It provides state-level data about U.S. residents and their health-related risk behaviors, including chronic health conditions and use of preventive health services like colorectal cancer screening. It collects data on the use of FOBT, sigmoidoscopy, and colonoscopy, basically asking if they've had any of these tests, and if so, when, and then it gives fixed time interval responses, so within the past year, within 2 years, within 3 years, et cetera. So with that, I'm just going to jump right in. So when you look at 2016 BRFSS data, it represents about 86.6 million adults aged 50 to 75 when you weight it to the census population. Of those, 67.3% were up to date, or 58.3 million, and 25.7% have never been screened, which is 22.2 million people, give or take a few. So when you look at those 86.6 million adults, a whopping 57.9 million are between the ages of 50 and 64, and when you look at 50 to 64-year-olds, only 35.8 million are up to date, and a very large 8.2 million have never been screened. When it's compared to 65 to 75-year-olds, 22.5 million of them are up to date, or that's about 78.4%, and only about 3.9 million have never been screened. So pretty big differences between those two groups. When you look at race and ethnicity, you can see the total population for each group I have listed there, and then obviously because it reflects the actual population of the United States, the vast majority do identify as white. When you can see a substantial number identify as Black, Hispanic, followed by Asian Pacific Islander, other multiracial, and American Indian, Alaska Native. But you can see when you look at the percent that are up to date versus never screened, and the numbers of millions of people that represents, you can see particularly among Hispanic Americans, they're sort of overrepresented in that never screened pile. When you look across all groups, regardless of how you slice and dice it, by age or race ethnicity, most have a proportion of insured that is greater than 90%, with the exception of people who identify as Hispanic. Only 83% of them report having health insurance, those who report annual income less than $15,000 a year, and those who report less than high school education. All of those are in the 80s in terms of their percent insured. So when you ask respondents, do they have a regular provider? Is a little more variable. Those who report more than 90% reporting that they have a regular provider, people who are 65 to 75, right there, people who identify as Asian or Pacific Islander or white, women, high annual income, high levels of education, versus those who report less than 80% report having a regular provider would be people who identify as Hispanic. And when you look at American Indian, Alaska Native, they also have relatively low proportions who say that they have a regular provider. All right, so when you look at the never screened by race or ethnicity and by these different characteristics, basically you can say that when you look at the Hispanic, people who report as Hispanic, a disproportionately high percentage of them report less than high school education, report annual incomes less than $35,000 per year, and lower numbers report being insured, which means obviously more of them are uninsured. But on the flip side, you can see that the majority of people do actually have insurance, regardless of race or ethnicity. All right, so just to talk a little bit about trends, fortunately or unfortunately, depending on how you look at it, BRFSS changed their methodology in 2012, so we can only go back to 2012. So our quote-unquote trend line here only has 3 dots on it. But I think you can see pretty clearly that it's been, the rates of colorectal, proportion of people who are up to date with colorectal cancer screening have been inching up slowly, not as fast as we might like. But you can see there's just this persistent gap between people who are 65 to 75 and those who are 50 to 64. The good news is amongst 65 to 75-year-olds, they're well into the 70% range, according to this data set, almost 80% really. And unfortunately, our 50 to 64-year-old population is just lagging way behind, and because they make up 2/3 of the total of this population, they're sort of dragging the entire national average down. So when you look by age and by race ethnicity, so again, you can see that among 50 to 64-year-olds, just across the board, regardless of race or ethnicity, their proportion of people who are up to date with screening is quite a bit lower than among 65 to 75-year-olds. But you can see the variation within those age groups by race and ethnicity and over time, particularly, and unfortunately my little red circles seem to have jumped off their numbers there, but when you look there at the end amongst Hispanics, you can see amongst 50 to 64-year-olds only, in 2016, 48% report being up to date with colorectal cancer screening. When you look amongst American Indian, Alaska Native populations, they're actually the only group that showed any improvement in that age group, from increasing by 6.3% from 2012 to 2016. And then when you look at 65 to 75, again, higher numbers across the board, but that doesn't mean that there aren't groups of people within that age group that are lagging behind. So particularly when you, again, look at American Indian, Alaska Native populations, much lower than white, people who identify as white or black, and also people who identify as Hispanic, definitely lower than we would like to see. So this is just an example of 2 extremes. So at the very high extreme, you have people who are age 65 to 75 who also report an annual income of greater than $75,000. They are reporting 86.8% are reporting that they are up to date with colorectal cancer screening, and at a complete opposite end is people who are 50 to 64 who make less than $15,000 per year. Only 49.4% of them are reporting being up to date with colorectal cancer screening. So that's not ideal, obviously. So sometimes people ask, well, what is going on? I'm doing all this work, we're screening all these people. Why aren't we seeing better improvement in our numbers? So again, obviously these are percentages, which means there's a numerator and a denominator. So we're only going to see increases in our proportion that is up to date to the extent that we screen people faster than the population growth. So you can see the total population between 2012 and 2016 grew by 4.8 million people. That's a relative increase of 5.9%, whereas the up-to-date population grew by 5.1 million, so that's a relative increase of 9.6%. So that's why our numbers are going up. So long as we sort of stay ahead of total population growth, we will be making progress. So again, this is just looking at population change by different groups. So you can see for most groups, the change in the up-to-date population has outpaced the change in the total population. So we're seeing gains in the number of people who are, or the proportion that are up-to-date. And then sort of somewhat conversely amongst the uninsured, you see the opposite, and that's largely because the uninsured population shrank. So some of those people flipped over to the insured population, but you still saw gains in that population because the up-to-date population shrank less than the total population shrank. And, so obviously BRFSS has limitations. These are estimates and more estimates and estimates on top of estimates. Obviously you have absence of information on subgroups. So, Asian Pacific Islanders is an extremely large group that contains a lot of variety. So it's hard to make any sort of extrapolation to any subgroups. And obviously this is self-reported data. So conclusion, we are making progress. Obviously we need to pay much more attention to people age 50 to 64, whether they're insured or uninsured, Hispanic populations, pretty much everyone, people age 65 to 75 who are American Indian Alaska Native, Hispanic, or have low income, and in general, just American Indian Alaska Native populations and Asian Pacific Islander, some Asian Pacific Islander subpopulations. And I think with that, I will turn it over to you.
Okay, and great. While we're getting you set up, I just want to remind everybody, go ahead and enter in any questions you might have. I know we have one from Shannon Dakin that we will definitely be entertaining at the end of the webinar, but also just a quick reminder that we do have that chat feature to key any questions in. Okay, just Mute, turning it over to you.
Thank you, Andy. And I'm so excited to share an overview of our HRSA Uniform Data System, or the UDS. And I also will be sharing with you some interesting findings related to the colorectal cancer screening from the 2017 UDS. I also want to recognize real quick in the room with me here today, my division director, Dr. Sue Lin, as well as my other team members who are on the line. My name is Miu Ratanawatkul. I work in the Quality Division, Office of Quality Improvement in the Bureau of Primary Health Care here at HRSA. Let me start off with why we do what we do at HRSA. At HRSA Health Center Program, our mission is to improve the health of the underserved communities and vulnerable populations by assuring access to comprehensive, cultural competent, and quality primary health care services. And our Bureau of Primary Health Care carries out this work through the oversight of the Health Center Program. In order to achieve our mission, one of the activities was to monitor the Health Center Program performance. And we do this by obtaining a standardized annual performance report from the program awardees as well as their lookalikes. So each year, the UDS report are due to HRSA by these program grantees by February 15th. So to talk more about the UDS is actually updated every year. And if you are interested in learning more about the specific requirements as well as the updates, the HRSA Assistant Letter, or the PAL, you can see that on the left-hand side of the screen, would be a great resource for you. And the PAL is actually published every year in May, and you can access it on the BPHC website along with other UDS manuals as well as instructions, definition, and UDS reporting requirements. As I mentioned, the UDS is collected on a yearly basis, so the data collection for our 2018 UDS is actually occurring right now, started January 20 of this year, 2019, and will be included in March of this year. Typically, our previous year data becomes available in the summer of the current year. So for instance, our 2017 UDS, which is our currently publicly available, most recent publicly available data, became available in the summer of 2018. So our 2018 UDS data will become available in the summer of 2019 this year. Now I'm going to get into the meat of what does our data set measure. We already talked about the timeline, so here is the type of data that's collected. So the UDS actually provide a great snapshot on the health center's information, including patient demographics, services provided, clinical processes, as well as outcome, and then our patients' use of services and costs. And you can see the list of the 11 structured Office of Management and Budget approved forms on the screen, as well as the 3 appendices. So these are required by all of our health centers who are rewarded through the 333 grant. Among the measures that are collected in the UDS, HRSA have been closely monitoring the colorectal cancer screening, which is one of the measures that we collect in the UDS. We collect the number of adult patients 50 to 75 years of age who have had appropriate colorectal cancer screening. And I pulled the definition from the 2017 UDS manual on how the percentages were actually calculated. So you can see that on the screen, our numerator as well as our denominator. I'm not going to go through the specifics because of the interest of time, but you can see that on my screen as well as in our UDS manual. So I wanted to provide you very high level of our data and what we've seen so far in our recent UDS data set. We obtained the national colorectal cancer screening rates as well as the breakdown of the rates by each state. In 2017, the national average for our colorectal cancer screening in the UDS was 42.02%. And screening rates throughout the United States were ranging from 17% to 63%, excuse me. And just to share with you a few other data analysis that we were able to run using this data set, in addition to comparing screening rates among states, we were able to also compare rates by sociodemographics. So UDS has sociodemographic information for each health center on various sociodemographic characteristics, and the one that I pulled specifically is on our patients best served in language other than English, as well as patients at 100% or below federal poverty level served. Two findings from these comparisons were, first, on the left, we saw that health centers with colorectal cancer screening rates less than a national average. And just to remind you, a national average in the UDS for 2017 was 42%. This cohort, those who are performing less than this national average, actually serve more patients in a language other than English. And then to the chart to your right, we saw that health centers who perform better on the national average actually serve more patients in poverty. When we look at our colorectal cancer screening rates and compared it by geographical location as well as practice size, using our 2017 data set, we saw that rural health centers had slightly higher average screening rates than their urban counterparts. But for their practice size, as you can see on the chart to your right, we found that the larger the practice size, the higher the average screening rates were. And we were able to actually use these findings in our in our technical assistance. So these findings, this analysis using the UDS data set were actually very helpful and insightful for us. And another analysis that I wanted to share with you, when comparing our screening data and our PCMH administrative data, we saw that health centers who were patient-centered medical home had higher percentages of colorectal cancer screening rates compared to health centers who were not PCMH. So this was actually something that we closely monitor. My team at HRSA specifically in the Quality Division, Office of Quality Improvement, we look at the progress of the colorectal cancer screening rates and how we are making great progress right now, but there's still a lot of work to be done. We work closely with our stakeholders as well as our partners at the NCCRT to provide technical and training resources to our health center programs. And my last few slides, you can access the UDS data on the BPHC webpage, and this data is actually available to the public. So when you go to BPHC website, you can see the breakdown of the health center data by the health center level as well as the state and the national level. You can also download the data into Excel spreadsheet for further analysis. Here is a list of the UDS resources. They are on our BPHC website again. Feel free to visit and learn more about our data set. And thank you. Here's my contact information along with my email. And to learn more about our agency, go to HRSA.gov. Thank you.
Okay, great. And now go ahead and transition to Mary.
Thank you so much. I want to thank the National Colorectal Cancer Roundtable for including me on this august group, because these data presentations, I would be filling up the chat box with questions already. This is really just such a wealth of information here. I'm from the National Committee for Quality Assurance, and my name is Mary Barton. I'm going to tell you about the HEDIS measure that we use to assess the health care that's provided to health plans that seek accreditation from us, or for Medicare plans, Medicare Advantage plans, all plans, whether they seek accreditation or not, are required to submit data to us. And colorectal cancer screening is one of our, I think, most impactful measures out of more than 70 that we use to evaluate health plans. So HEDIS is the acronym, stands for Healthcare Effectiveness Data and Information Set. We are glad to use these measures for improving performance. The goal is not necessarily to tell health plans that they're bad. We'd rather tell all the health plans that they're great. And when we look at, as I mentioned, the more than 70 aspects of health, we're trying to assess the quality of care and the comprehensiveness of care that health insurance plans provide to their members. So just to highlight up front, what's different about this than HRSA's data set is that we're looking at people who have health insurance, typically either commercial, Medicaid, or Medicare, that's administered through a health insurance plan. We are looking at actual data in their health record, so different from the National Health Interview Survey or BRFSS, where you're doing surveys asking people to recall what's happened to them in the past, which has, you know, great advantages and also some disadvantages. We're looking at data that's in a person's medical record. And so the next slide, just to highlight, 190 million lives, which is 58% of the U.S. population, are included in the measures that are reported to NCQA through HEDIS. And to get to the colorectal cancer screening measure, which I'm sure you're all very interested to hear about, we're looking at adults aged 50 to 75 who were enrolled in the health plan, who were screened for colorectal cancer by any of the following. So any of these would suffice to say you had achieved screening. So a fecal occult blood test, fecal immunochemical test annually, a flexible sigmoidoscopy within the last 5 years, a colonoscopy within the last 10 years, CT colonography within the past 5 years, and FIT DNA within the past 3 years. And this measure was reevaluated within the past 2 or 3 years to be consistent with the U.S. Preventive Services Task Force recommendation around colorectal cancer screening in the general population. And this measure relies on administrative data as well as medical record data to supply the data elements in it. So as an overview, what do we see? Well, commercial plans are moving, but not very fast. But Medicare plans are really showing how it can be done. So here's the average national performance between 2010 and 2017. And the red bars are Medicare, and the gray bars are commercial. So what we see, and this is very similar to the data that Stacy showed us up front from the National Health Interview Survey, you've got a steady improvement over time. You have faster improvement in the Medicare population, which is, of course, in addition to it's a different health insurance, it's a different age group. So it's people 65 and older as opposed to commercial, which is just going to be the people 50 to 65. And so what you can see here is that 2017, the most recent data, we actually have a 70% average national performance for the Medicare population, which is really really terrific. And on this slide, I'm showing the distribution of commercial plan performance. So the blue bar in the middle, the light blue, shows the mean commercial plans performance in 2013 through 2017. And the 10th percentile down below that in gray is the plans who are doing the worst, right? They're the folks in the first 10th percentile. But the dark blue up above is what the 90th percentile is achieving. So these are health plans that are achieving an over 70% screening rate for their members, almost by definition, between the ages of 50 and 65. So again, there's some spots of excellence in here, and I think interesting food for potential further study. So this, back to the headline at the beginning, it's not very impressive what commercial plans are doing as a whole in terms of their achievement. So over the past 5 years, the number of commercial plans that have posted a rate over 80% have actually decreased. So there were 11 in 2013, now there's 7 this year. And what health plans tell us typically is that, commercial business is important to them, but the Medicare STARS program is really important to them. And so that's where they tend to, in some cases, may focus their efforts. But I'll get to the Medicare performance in just a minute here. I want to continue showing the commercial plans with a rate greater than 80% in 2017. I told you there were 7 of them. These are the 7. So, quality plans typically who are organized around providing good population health, excellent population health, and when they when they put their minds to it, like I think Kaiser's one example of instituting a widespread mailing program to members to get FIT into the hands of members of the screening age. We see that there's innovative thinking going on in these various places, and experimentation and trials of new techniques to try and improve their overall screening rates. Now to move to Medicare plans, and we have the same graph with the mean in the middle and the 10th percentile below and the 90th percentile above, and we can see the shift here, that the mean is now up to 70, that the 90th percentile, which is the best performing plans, are all over 80%, while the 10th percentile is lagging considerably, down around 50%. So this is really should be another one of the punchlines. The number of Medicare plans that are screening more than 80% of their members has increased. If I was to match a curve to it, I might say exponentially, might be linear, can't quite tell it right yet, but so from 25 back in 2013 to 69 in 2017. And this, I think, is really a great example of how an incentive works to improve care, because the Medicare STARS program includes incentives for health plans to perform well and gives them a better better situation if they have a high score. And so the score on their Medicare population really matters to health plans. And so we see this really impressive increase in high performance. Also, it tells, there's another story it tells, which is that the way to get to over 80 is not a mystery. Right? The plans could tell each other, or they could look around and to their partners and see how they did it. And presumably the commercial health plans for the slightly younger population could also pick up the same tips and tricks from their partner plans. And here is I had to pick the top 10 Medicare plans because we couldn't fit all 69 on a slide, but this shows you the performance rate for these health plans for 2017, and we've got the top two above 90%, which is really terrific, really excellent, and I guess again shows you that if you're able to put your pedal to the metal, you can really make a big improvements in screening this population. So with that, I'm looking forward to the discussion that we're going to have. Thank you all very much for your attention. There's my contact information. Happy to answer questions now or later. And I can pass the slides back to Andy.
Awesome. Thank you. Mary, thank you so much. I think seeing that Medicare data and then looking at some of those real bright spots are an amazing way to round out the discussion. We have about a whopping about 7 or 8 minutes per question. So I'm going to knock off a few that we had, which are, can we get access to these slides? So yes, the answer is yes. We will definitely be sharing and uploading these data sets and these slides on the NCCRT website. And I showed you all the website linkages earlier in the presentation at the outset, so we'll make sure and share those again. But yes, we definitely will have that information and all of these great data points and data sets available. So I'm going to go ahead and jump into questions, and then we'll share just a couple of updates at the very close related to NCCRT opportunities. But the first one is actually coming in to Stacy. And Stacy, thanks again for joining in with the cold. I'm sorry to hear that. The question is specifically, does the NHIS include American Indian as a rates option for the respondents? There was the noticing that the screening rates are often, and I'm trying to scroll down, are often specifically, hold on just a second. And Emily, I don't see, it's kind of jumping to the question. Specifically the race option, but I guess actually I think I'm sorry, Stacey, you can probably see that as well. But I think the question that Shannon was posing was directly on connecting and sharing information about Native American, American Indian, and probably Pacific Islanders as well. Stacey, can you go ahead and answer that question quickly?
Sure. And sorry. So that is an option, and we didn't analyze that as part of the trends over time, but just to let you know, using the American Cancer Society screening definition among people 50 years and older, so this is slightly different than the U.S. Preventive Services Task Force. The screening rate among American Indian and Alaska Natives was about 54%. But I think for some reason we couldn't harmonize the race ethnicity coding for that over time, so I didn't show that in the trends. And the Pacific Islanders, that's a great question. I don't think that we have enough power to look at them separately, but I can definitely get back to you on that because I'd like to double check that on my side.
Okay. What was, and then this one, a question coming in from Kathleen Connors. What was the change with the collection method? And I think this is relevant to Mu's presentation, or actually it might have been Janaba's. Oh yes, what was the change with the collection method with the BRFSS? And I'm sorry, I'm not sure why this isn't. And Emily, can you see the questions in full? Because they're getting cut off just a smidge. What was the change with the collection method? Can you see it, Emily, all the way?
Yep. What was the change with the collection method with BRFSS as of 2012? Has this enhanced the collection method?
So this is Janaba. So they didn't actually change the way they do their sampling. What they did was change the way they weighted after it's already collected. So they're still using landlines and cellular phones in the same sampling method, but the way they weighed it was changed to be better representative of the population as a whole.
Okay, thank you. And then Emily, I think that this one was, I think the next question we had after Kathleen was from June, is that correct? So what was the criteria for determining practice size? The practice size, I think, for the specific questions, and Emily, can you help me out there so we know who to punt that one to?
Right, so what was the criteria for determining practice size? And I think that was in reference to Mu's slides on UDS.
And you might be on mute, but if we could have you jump in for that, that would be great.
Yeah, I was on mute. I'm here. So the question was, what was the criteria for determining practice size? So specifically for our practice size, I believe we looked at literature review to determine what is a good cutoff, looking at defining large, medium, and small practice size for the health center. I don't recall the specific number right now, but I believe that was what we used to determine the size of the health centers. And it could be by the number of patients served at that health center for that year, for 2017.
Okay, great.
Yeah, and then I believe,
go ahead.
So, sorry, Andy, and I think Patty asked a question about including multi-target stool DNA testing in the UDS as an appropriate screening method, if we have any plan on including that. So as I mentioned on the PAL, or the Program Assistant Letter, in 2018, actually, colorectal cancer screening has been revised to align with the CMS 130V6, which is, if you click on that particular link, it will show you a list of our measure, and then the multi-target stool DNA testing is actually going to be included in our 2018. So the health centers who are responding or reporting to this measure this year will actually be, will get this question.
Okay, great. Thank you for that clarification. And I do know Shannon has another question, but let me ask Emily if we can pop down to David's question specifically, because can we determine or theorize? And then Emily, can you read that question for us real quick, and we can punt to one of our panelists?
Sure. Can we determine or theorize how important Obamacare and or Medicaid expansion were to these increases?
I can answer that. Hi, David. I'm actually working on a paper right now that's under review, and I'd be happy to share that once we have it accepted. But that specifically looked at Medicare expansion. We didn't look at the impact of the federal marketplace on cancer screening uptake.
And so is that once the paper is in circulation, we'll have more information? Is that correct, what you were saying, Stacey? Okay, great.
Yes,
got it.
We're working
Perfect.
on it. So,
we're working
and I can,
on it.
Yeah, we're working on it. I'd love to share it once it's up.
Okay, perfect. Are there any other panelists who want to address, I guess, that particular question? Because I think a number of folks can actually address that. Mary, anything particular that you're thinking based on what the expansion for Medicaid has done for the screening increase?
I think that, clearly the Affordable Care Act has increased the number of people who have health insurance. And so part of that is in the sector of the insurance net, horizon or environment that is exchange plans. And exchange plans are supposed to report measures starting, I think, last year, but that has not been publicly reported yet. So my presentation does not include data from exchange plans. Another part of it is, of course, the great expansion in Medicaid. And I think that we're going to see changes over the next several years as more and more states expand Medicaid in what the Medicaid plan population looks like. I don't think that that's a driver of the improvement that we've seen to date in Medicare.
Okay, thank you for that. And I want to go ahead and just see if any of the other panelists would like to respond to that, because I think what we will do is go ahead and take any other themes and questions, punt those to our panelists, and go ahead and put out some additional answers to questions that we weren't able to get to today. But I would just ask, I think, Janaba and you, anything else in closing of related to the particular question around Medicaid expansion and your perspective on if that's helped, if it might be a factor going forward?
Yeah, this is Janaba. So I don't think I have any hard data, but obviously I think we know that people who are uninsured obviously have much lower screening rates, but we also know that insurance by itself rarely does anything. So I think it would be hard to isolate the effect of insurance by itself. It is usually the combination of insurance plus activities or interventions or programs or funding to support efforts to really support providers and the population, patients, to engage in colorectal cancer screening. So I think you need to have both. Either one of those by itself is probably not going to do the trick.
Okay, great. And you, any final thoughts as we get ready to close down?
Yeah, our thoughts at HRSA, so we, to support our health center programs, looking at the different clinical quality measures, specifically colorectal cancer screening, we also try to look into various social determinants of health and see, what are some of the areas that HRSA could provide additional training and technical assistance resources on, looking at those areas in addition to having, insurance. So our thought is that, along with what Janava has stated, it's not just access to insurance or access to health care, but there are other, other factors that would affect whether or not someone would obtain colorectal cancer screening. So at HRSA, we are aware and we are closely monitoring this measure and looking for ways to improve these cancer screening rates.
Okay, excellent. So with that, we're going to go ahead and actually close down the Q&A. And again, I know there's a couple others that we'll get to and make sure that we send some response. We've had an outstanding participation today. Thank you tremendously to all of our presenters. And I did want to give a shout out to the live broadcast that's going to be happening March 7th for the roundtable and partner organizations that are going to be kicking off the Colorectal Cancer Awareness Month, the launch of the 80% in Every Community campaign to spread awareness and the celebration and success. So there will be a website to register to go ahead and get this moving and going, and even looking at entertaining the idea of a watch party in your neighborhood or within your cancer community. And we'd really like you all to connect with us on social media. And I should just say that I think that as we close out the 80% by 2018 initiative for that the time frame of 2018 that has now passed, this data will continue to tell great stories about where we're going. And so this has been fantastic to hear. I know part of us who've been really engaged in looking at how will we conclude if we've been successful and where to go with these data sets, seeing this now culminate has been an amazing opportunity. So thank you again for all of our panelists, everyone for joining today. And a quick reminder that the slides will be uploaded, and there's a wealth of information for other data sets that are available on the NCCRT site. So with that, have a great afternoon, and thank you so much for joining today's webinar. And again, a huge thanks to Emily Butler-Bell, Caleb Lavelle, and the entire ACS and NCCR team for all of the great support. Have a great day, everybody.